we'll move into segment 5, which is measuring hospitalizations and identifying facility providers. So for this segment, I really want to discuss hospitalization information that's available for Medicare Advantage beneficiaries. We have a couple of options. As Becky mentioned, we have the MedPAR file and the Inpatient Encounter Data file. So we'll talk a little bit about each of those files in turn. And then we'll talk about how to characterize the type of hospital. We mentioned that typically with the fee-for-service data, we use the CMS certification number, or CCN, used to be called the Medicare Provider Number. We used to use that to say what type of hospital was billing in the inpatient file, but because the Medicare Encounter Data don't have that, we need to use some other options. So we'll talk about linking that with the NPPES file. And then we'll talk a little bit about issues you might run into if you're trying to identify or count hospitalizations and diagnoses. And then within each of the two files, MedPAR and Inpatient, we'll talk about some select variables that you might be interested in. So just a review of what Becky had mentioned, there are the Inpatient Encounter file. This is the Encounter Data workshop. We're talking about Encounter Data. The inpatient file is the source for inpatient hospitalizations within the Encounter Data. And when you order it, you actually get a suite of files, a base file, revenue center, condition code, occurrence code, etc. So that is the inpatient encounter file that started being available in 2015. The MedPAR file has been available for a lot longer than that. It's not a file that explicitly contains claims data. It's actually a rulemaking file. So some work has been done to it in order to make it more usable for those who are trying to evaluate policies or put policies into effect. And it includes both inpatient hospital and skilled nursing facility stays. It goes back to 1999, and it has all fee-for-service information, but it also has Medicare Advantage beneficiaries. It really increased the number of Medicare Advantage stays that are included in the file in 2008 because of the way that the hospitals are paid for those beneficiaries. However, there have always been some concerns about under-ascertainment of Medicare Advantage beneficiaries. So we'll talk a little bit more about that as we go through this session. So we'll start talking about the inpatient encounter file. Who's included, what's the structure, some key variables. So this is for Medicare Advantage enrollees only. You won't find any fee-for-service hospitalizations described in the inpatient encounter data. And so this is any Medicare Advantage beneficiary for whom encounters or chart reviews pertaining to an inpatient stay were submitted by the plan to CMS, so reported in the encounter data processing system. The services that are included include short-term acute care hospitals. That's what the first thing I think of when I think of an inpatient hospital stay, and also includes critical access hospitals. Those are a special kind of hospital that CMS designated as really being essential to their service area. There might not be another hospital for a long way, so they get some different payment incentives from CMS, but they will bill, or their encounters will show up in the inpatient encounter data if a Medicare Advantage beneficiary was seen there. It also includes inpatient rehab hospitals, so those might have a little bit of a longer stay. Also inpatient psychiatric or specialty hospitals, cancer hospitals, for example, and long-term care hospitals also will show up in the inpatient encounter data. And then there are also special units within a short-term acute care hospital. So there are, buildings that are designated as inpatient psychiatric facilities, but then there also might be within a standard acute care hospital a floor or a wing that is used for inpatient psychiatric use as well. And so those services will be included in the inpatient encounter data. So this is an annual file, so you order it by the calendar year, and encounter records and chart review records are included based on their claim through date. And there is quite a lot of date information included in the files. There are claim from and through dates and admission and discharge dates. Oftentimes those will line up, but not always. Sometimes a stay will span more than one, more than one stay date. So you'll have, or more than one claim date, or a provider might submit more than one encounter, for example, but if a admission is especially long. And then there are procedure dates on the base claim file that will give the date that each of 13 possible procedure codes. So there might be ICD-10 procedure code 1 is listed, and then there is a procedure code date for the first procedure, and that can happen up to 13 times on the base claim. There are also revenue center from and through dates on each revenue center line. The revenue center file also includes the claim through date if that's helpful for you as well. But so Becky had a slide like this, just a reminder that when we're talking about institutional encounter files, so this is also true for the skilled nursing facility file and the outpatient encounter file, because they bill on a particular form, they're laid out in a similar way. We have a base claim file that has a lot of the basics of the encounter. So it has, the dates, admission, discharge, claim from, claim through, a provider number, so the NPI, the organizational NPI. It also has the plan information, so the contract and plan IDs. It has up to 25 diagnoses, 13 procedures, and then the admission and discharge status as well. For more detail about what happened during the stay, then we have a revenue center file that you can link using the Beni ID, claim type code, and encounter join key. When you link those, then you get more detail about, were there ER charges billed, for example. You can look for the emergency room revenue center in the revenue center file, and then link to the base claim to get all of the other information like diagnosis codes and things like that. And then there are, the condition code files, occurrence, span, and value codes. Those will give you more information. So the span codes have a lot of date information. So if there was a prior stay, so if you're looking in the skilled nursing file, facility file, and you need to know how they qualified for skilled nursing facilities, different Medicare Advantage plans may be structured similarly to Medicare fee-for-service, which has a requirement that you have a prior stay in order to have skilled nursing facility covered. Or, it might be that your benefit has run out, and so there might be some information on dates there. Condition codes, talk about a little bit about whether this stay was in a disproportionate share hospital, for example. And there are value codes that kind of talk about different things that are applied. Now, I very rarely use these even in the fee-for-service data, and I have not used them really at all in the encounter data. So I don't have a lot of information about how well these are populated, but they are available to us. And then we have a question about whether it's possible to identify observation. And yeah, so there are revenue center codes associated with observation room use. And I think a good place to start, as Becky mentioned with the emergency room, is how is it billed in Medicare fee-for-service, which revenue center codes are used. There are standard revenue center codes that are standard to the billing form, and they, there's one for observation rooms. Now, the caveat is that I don't know how the plan is directing the providers to bill for it. And I also, different hospitals, may not, I can't imagine a hospital doesn't have a separate observation area, but one example is, a hospital does not have a trauma ICU. If a traumatic injury comes in and doesn't need to leave for some reason, then they might be in the general ICU. So sometimes you have to be a little bit more general with the revenue center codes, because they wouldn't use a trauma revenue center code for that hospitalization because it was in a general ICU. So anyway, those are our revenue center code considerations that we'll talk a little bit more about later, with the added caveat of, I know how it is requested to be billed in Medicare fee-for-service, and I don't know necessarily for every Medicare Advantage plan if they are collecting that same information. And And there's one other question about how readmissions are captured in the encounter files, and similar to fee-for-service, you would need to look at the dates of the hospitalizations to know, that one follows another one. You may need to also look at the provider to make sure that that it's happening at the same provider. You would likely want to remove any stays that are for inpatient rehabilitation, for example. So there are a few steps, and for more information, you can contact ResDAC at umn.edu for more information about some of these, more in-depth questions. And then a review of the encounter records. They are just a description of the service sent from the plan to CMS. They're not a bill. They're not necessarily used even for payment. They may have originated as a claim for payment from the provider to the plan, but what we see is what the plan is sending to CMS. The reason they are submitted to CMS is they are used to calculate the risk adjustment to determine how much the CMS will pay the plan. So plans do have an incentive to make sure they are rigorously reporting diagnoses in order to get the highest payment that they can. When I looked in 2021 in the inpatient file, 42% of records, just lines in the base claim and the base file, or excuse me, the base encounter file, are chart reviews. So that tells you how much they are being used, and it's not unusual to find. If you look by BeneID, you'll find, many chart reviews, certainly more than one, associated with the same claim from and claim through date. So it's not just they go through and add one chart review onto a service. It tends to be many for one service. And then, as I mentioned before, there's a kind of a strange small proportion, less than 2% of stays, looking by BeneID and date, that don't have any final action code records. They don't seem to have any service records. They're only chart reviews. So it's hard to know how those, what to do with those. The other thing is that encounter inpatient files do include service records describing utilization, which would be more akin to what we see in other inpatient files. They may have more than one record per stay. So there are ways, as Becky mentioned, using like the claim frequency code to see whether it's a replacement record for a previous encounter, for example. So there is some cleanup work to be done. Here's one example of something that we found. It was a good enough example that I thought it would be worth it to share. We have 2 lines from the same beneficiary ID, and these are mocked up data, but they're based on a real example. So not the same BeneID, not the same claim from and claim through date, but still we made it as real as possible here. So we have, and they both have the same claim from and claim through date. So I wouldn't probably want to count this as 2 hospitalizations. They look like 2 records for the same hospitalization, right? But one of the kickers is that they have 2 different organizational NPIs. And it does become difficult then to say, well, which one of these records am I going to keep? Which, if I'm trying to attribute them to an NPI, which one would I want to do? The other thing to note is that here, the claim admission date does not fall within the claim from and claim through dates. So maybe that's a good indicator that this is not the record to choose. But this is the kind of thing that you might see. And this is very much an aside slide, but this is true of fee-for-service data, but a very small proportion of the records will take most of your time. There are a lot of records that are very straightforward. If you made a decision to not include chart reviews, you're going to end up with a lot of very straightforward service records. But there's always going to be these few that you're going to have to kind of take a look at and make a decision about. The best we can say is to really document your methods. In a perfect world, you'd get a chance to, be very precise and, all the decisions that you made if you're writing a peer-reviewed article or a white paper. Or, if you can't include it in the body, maybe there could be a supplement for your methods, but at least keep records in case someone asks. there's lots of decisions to be made in any of these analyses. Who are you including and excluding? How are you handling chart reviews? How are you identifying these duplicate records? Have you made any simplifying assumptions? It's kind of easy to say, I'm not going to include chart reviews because I don't think that they make sense in the context of comparing to something else, something like that. And also sensitivity analysis. If I made a different decision, do I get a different answer? Sometimes that can be really informative as well. So that was my little aside. Key variables in the Encounter inpatient file, again, are your diagnosis codes. As Becky mentioned, there's 25 per record. In addition, each of those 25 diagnosis code fields has a second field that indicates whether or not that diagnosis was present on admission. And then there are also diagnosis code fields that are specific. They only are filled if there's a mechanism of injury code billed on that encounter. And there, I think, can be 2 of those. So you can have 2 separate codes on one line. There are the diagnoses will appear on both chart review and service records. There are also 13 procedures, and then there's a date of service associated with each procedure. Funnily enough, and I'll talk about this a little later, there are procedures on chart review records as well, so you can take a look at those. I think it relates to maybe how they are getting reported into the encounter data system. I'm not 100% sure why that is the case, but and then also both diagnosis and procedures in Medicare fee-for-service are used to calculate the diagnosis-related groups. And I would not be surprised if Medicare Advantage plans also pay on diagnosis-related groups. There are DRGs that are specific to Medicare, and then there are other DRGs that are for other plans to use if they want to use. So you can take a look at what the DRGs are. In Medicare fee-for-service, they are related to the prospective payment system. So you can look on the CMS website and see, for this DRG, what are the diagnoses and procedures that get this DRG assigned. There are sometimes other factors like death during the hospitalization or something that are used to calculate the DRG. But you can look and then you can see the payment associated with it. And that can be helpful because Medicare Advantage or the Medicare Advantage encounter records don't have payments. You could use the calculated DRG or derived DRG to say, this is what it would cost in Medicare fee-for-service. But again, sometimes the claim DRG code is not filled. The derived DRG code does go ahead and calculate as it would with the prospective payment system based on diagnosis and procedure code. So those can be helpful. So if I said, I really want to look in the encounter data file for hip fractures in the encounter inpatient file, I want to see, I want to do some study on those who had neck of femur fractures or, kind of colloquially called hip fractures. This is just from the 20% sample, a 20% random sample of beneficiaries. Remember, if I'm looking by diagnosis code, a hip fracture would be a diagnosis code, I'm going to be picking up both chart review and service records. And indeed, I do get mostly service records, like 72% or so, but I get quite a few chart review records as well. And the interesting thing is that 12% of the chart review records have a procedure code. 55% have an admission type of emergency. It makes sense that the admission type would be emergency for a hip fracture. Other admission type codes, though, like there could be an urgent admission. So this 75% isn't, and there's also a trauma code. I think that gets you up to over 90% of service records. But just to note that there's an admission type code variable on the file, but it is filled out for chart review records, which is kind of confusing. There is also a discharge status code. And if I looked for whether or not someone was discharged to a skilled nursing facility in the service records, I get 55%. My point in this table is not necessarily to explore the differences between the chart review records and the service records, but more to say, if you had forgotten or your code didn't work like you thought it was going to, and you didn't exclude chart review records, you could possibly be getting different answers than maybe you would even want. because these fields are filled on chart review records. And so it is a little bit confusing. You probably want to make sure that you're excluding them. If you're getting answers that don't seem quite right, you're expecting more procedures or something, that might be one thing to go back and check. I mentioned that the Revenue Center file does give more detail about the areas of care used during the stay. So this is a repeat of what Becky had in her slide, but it's just a good example of, you can look in the Revenue Center file for revenue centers specific to emergency rooms. And then you can see, whether or not the emergency room was charged during the stay. And I already gave the caveat of some hospitals, emergency room is pretty standard, but there are some very specific codes if you really wanted to know if someone had a trauma ICU admission, depending on how you count it, you may only care that they were in the ICU after a traumatic injury, not necessarily that they had to have a trauma ICU revenue center code, and that will get you probably more than just like insisting on a very specific code. So on the encounter data, we do have contract and plan IDs as well. So you can just use the data if you want to search by a specific plan, or if you want to do an analysis, how many am I getting for each plan kind of thing. You have that ability. And if you want more information about the plan characteristics, you can link it to the plan characteristics file. You just have to note that the variable names are different. The same concept though, contract num will link to contract ID. So the other key variables on the inpatient encounter file are the organizational NPI. Again, this is an intelligence-free identifier, meaning it doesn't really mean anything to look at the numbers and which spaces they hold within that identifier. And so you can't use the structure of the NPI to identify the provider type. There is an organization taxonomy code on the encounter data file itself. It's not routinely filled, however. So in 2019, about 42% were missing. You can link it yourself to the NPPES, the National Plan and Provider Enumeration System. It's a public use file that's free. And so you can use the taxonomy codes there to separate provider types. Just note it is possible for a provider to have multiple taxonomy codes. So that's something to be aware of. This is what the taxonomy might look like. So if you had this taxonomy code, there's a group part of the code that might, say it's a hospital unit. And then there's a classification part of the code that tells you, what kind of unit it is. And then we might translate that to say, well, it's a unit within a short-term acute care hospital. If you had one that was in hospitals and then had rehabilitation hospital as the classification, then we might call that a rehab hospital instead of a unit within a hospital. But these are the different types of units. So you could also have, skilled nursing facilities, for example. Now we're going to move to the MedPAR file. Now the MedPAR file is structured differently, but the services included in the MedPAR are similar to the encounter data. It does include short-term acute care hospitalizations and those from critical access hospitals, inpatient rehab hospitals, all of those. One thing it includes that are not included in the inpatient encounter is skilled nursing facility stays. We're not going to talk really about those stays, but just be aware that they are included in the MedPAR. That's part of that rulemaking. They wanted to have in one file, what happens to someone after they're discharged. In one file, you'd be able to tell if they went to inpatient rehab or if they went to a skilled nursing facility. So that's helpful for that. It isn't also a calendar year file, but the inclusion criteria are slightly different. Skilled nursing facility stays are based on admission date, and hospital stays are included based on discharge date. And again, the way I remember that is, well, they want to be able to track people, so it's better if the discharge date and the admission date are in the same file. It's more likely that they would end up in the same file that way. But the MedPAR population is different. It does include both Medicare Advantage and fee-for-service stays, as we mentioned. And the way that Medicare Advantage stays get into the MedPAR is also different. This is a result of shadow billing or information-only bills, and they do come straight from the provider of services, so the hospital, to CMS. The hospital wants to send this information to CMS because there are pass-through payments that are calculated based on maybe the number of Medicare days billed. So they want to get credit for both the Medicare Advantage beneficiaries and the Medicare fee-for-service beneficiaries. Some of those programs are the disproportionate share hospital program, graduate medical education, indirect medical education programs. They need to have an accounting for how many Medicare days the hospital is billing. Some hospitals don't receive these payments. They're not a teaching hospital, they're not a disproportionate share hospital, and that is why in the past we've always kind of been concerned. We know that not every Medicare Advantage hospitalization is going to get sent to CMS from the hospitals for this reason. The hospital isn't required to send them if they're not receiving a payment for them. And so we've always kind of said, well, you know, if there's a stay in the MedPAR file, you can be pretty sure, like you can use that as a denominator and see what happens. But it might be an incomplete if you're looking for all Medicare Advantage beneficiaries and you want to know all of their hospitalizations, you probably don't get that from the MedPAR. So if you want to look in the MedPAR and find stays paid by Medicare Advantage organizations, you know, the best way is to use the MBSF and say, I know that during this month, this beneficiary was enrolled in a Medicare Advantage organization. We're going to assume this is an MA paid stay. On the MedPAR itself, we have 3 different variables. There's a claim type variable that is associated with encounters. These are the values associated with encounters. There are, or I should say, with Medicare Advantage stays. The group health organization paid code, if it's missing, then it's not paid by an organization, a private organization. And then there's an informational encounter switch. And I should note that skilled nursing facilities also report shadow claims to ensure proper recording of qualifying stays. And so you can use these as well to identify those. The variables have been used differently over time. If you go back to 2011, pretty much using the claim type code or encounter switch will give you the same information, but the encounter data switch, you know, came online in 2011. So but prior to that, you'll have to use different codes. So this kind of just shows you that even though the GHO paid code has been around for longer, you may, in years that you can do it, prefer other variables to figure that out. But again, the MBSF is the best place to look. I keep saying stays when I'm talking about the MedPAR, and that is because it is a stay level file. It's not even a claim level file, it's a stay level file. So if, you know, even in the fee-for-service program, if a hospital submits multiple claims for a single hospital stay, like, you know, it's a very long stay and they, you know, it passes their fiscal year, so they want to close out one claim and open a new claim during the same stay, they might submit multiple claims. In the MedPAR, it doesn't matter, it's already rolled up for you. But what that does mean, because we have one line per stay and there are no supplemental files, it's just one file, all of that detail information, like in the revenue center, it has to get transmuted and transposed into a variable for you. So you have variables like the emergency room charge amount. So instead of looking in the revenue center file for an emergency room revenue center, you're just going to look at the emergency room charge amount variable, and that will tell you, was there a charge to the emergency room revenue centers. There are also flags that might say, yes or no, this person has a ICU revenue center. And the information is usually taken from one claim only. Sometimes it's summed, but the final claim might be used to populate a field. So if it's not a summary or a yes, no, this appears on any claim, then sometimes the information is just like, this is the final information that we have. Again, we have 25 diagnosis codes. We now have 25 procedure codes, and there are diagnosis related groups. It may not apply to the Medicare Advantage organization payment. So They might just be present and are not actually related to how much the hospital is getting paid. There's, like I said, if you want to know if a hospital department was used, you can find summary variables. There are day count variables, so you can see how many days they might have spent in an intensive care unit. The CCN that I have referenced multiple times is a 6-digit certification number for a facility, and this is present on the MedPAR. And for all stays, it is present because the hospital is reporting to CMS, so they want everything grouped under their number. The first 2 digits are the provider state code, and then the final 4 digits give information about the type of provider. And you can find more information at this link about the different types of providers. Critical access hospitals have are in the 1300 series here. So that can give you more information about what type of provider is it. Is a psychiatric hospital, short-term acute care, long-term care. And then sometimes you'll see a letter here in the 3rd position, and that happens when there is a unit within a broader acute care hospital. So M and S here would signify psychiatric units within a hospital. They take the hospital's overall CCN and just replace that with a letter. Prior to 2021, MedPAR did not contain the CCN with the special unit codes. So what it would have is the MedPAR provider number. They take the special unit codes out and replace the number depending on an algorithm, which you can find in their code book. And then you can always use the range of the final 4 positions to characterize stays. What they do with the special unit code is they put it in a separate variable so you don't lose it. And so then you can get more information about, whether or not there was a psychiatric unit within an acute care hospital that's used. And the organizational NPI is also available on the MedPAR. So you might think, well, that's great. You have a crosswalk right there. One thing to note is that it is possible for one CCN to be associated with multiple MPIs and vice versa, which is why there's really not a clean crosswalk that's published anywhere. So it just does becomes a challenge. When it's on the MedPAR, it's from the first claim recorded in the stay. Again, the NPI is intelligence free, so it doesn't give you any information about the type of provider or even where the provider is located. When we look in the 2019 MedPAR, we have 7,800 unique CCNs, 79. And when we say recreated, that means from the portion of the base CCN and the special unit code. 7,900 unique organizational NPIs, but sometimes either way, one can be associated with more than one of the other. The CCN, if you are interested in more information about the hospital, can be linked to the provider of services file and the healthcare cost reports, the healthcare cost reporting information system, or HCRIS. That gives you information about what the hospital is reporting out to CMS about how they're, the types of services that they're billing for, how much they bill for each service. But the NPI can be linked to the NPPES or NPPES file. All of these, the POS, the cost reports, and the NPPES are all public use files. They're all free. So we did a little bit of comparing of the MedPAR and the Encounter inpatient file, because you might be wondering, which one would I want to use to measure hospitalizations? We wanted to kind of characterize stays that are found in one file or the other, or both files. What we did is we limited to short-term acute care hospitals and critical access hospitals. We created our own kind of CCN to MPI crosswalk using the MedPAR file identifiers, and then used the NPPES to create a taxonomy similar to what we might get from the CCN in order to look at the encounter stays. If we assigned based on the NPPES for encounter stays, do we get something similar to what we got in the MedPAR file? And then we deduped the encounter stays in order to try to create a stay level file. Then we matched the two. We tried to match as many records as we could based on the NPI and the dates and the beneficiary, of course. For stays that we were able to, or for stays that had a CCN match, meaning stays that were, in the MedPAR, we linked to the cost reports to get more information about whether or not that hospital was receiving DISH, GME, and IME payments. And then we also got some information about the hospital size. Again, with the encounter data, we excluded the chart reviews, and in order to get that stay level file, we deduplicated based on the Beni ID, claim from, claim through, and organizational NPI, and aggregated into stays based on the Beni ID and admission date, although 2% of stays were missing admission date. For the MedPAR, we limited to those who had, who were likely from, billing from a Medicare Advantage organization. So informational encounter indicator switch is yes. And then we limited to the short and long stay records. So we excluded the skilled nursing facilities. And we matched by Beni ID and admission date. And as often happens, we did give it a little bit of wiggle in order to account for any possible difference in how the admission date was listed. So we gave 3 days. And when we looked at the way we might categorize based on combining the NPI and the NPPES taxonomy versus what we would get from categorizing based on the CCN, we find some really good matches for some types of facilities and less good matches for others. So the short-term acute care hospital with a psychiatric unit, if a stay happened there, we were least likely to match that happened either from the MedPAR, we were categorizing it. Can we also identify it that way based on the NPPES? That was trickier. But inpatient rehab, luckily, was quite good. Whether it's a short-term acute care hospital or a critical access hospital, those were good. We struggled the most with, units within an acute care hospital. And this is the Venn diagram of what we found. So unfortunately, it's not like one of these is a gold standard and it includes all of the stays and then the other one has less. It actually is more of a Venn diagram and overlap. So there were about 4 million stays in both the MedPAR and the Encounter. The MedPAR itself had 4.4 million, and the Encounter had 4.6 million. So, and if we looked at the total stays from the total short-term acute care and critical access stays from both, it was about 5 million. So no one source provided all of the stays. When we look at the match rate, and we did this over time to see, and it actually, it is improving, but this is, how many of the MedPAR versus the total and how many from the Encounter versus the total. So neither, again, gives us everything, but Encounter has kind of gone up a bit. And that was through 2018. We're not the only ones that have tried this. MedPAC's been working on this. They've got a report from 2020 that I've linked down here and from 2024. Oops, I don't have an end to that sentence. But they were also looking at other service types as well. So they didn't just do Encounter, Inpatient, and MedPAR. They looked at other services. This was similar also to findings from Jia Zheng and her group. I have the link for that down here. They found about 5% of MedPAR stays weren't included in the Encounter data in 2015. I think there's been more work done since then. So all similar findings. We wanted to look at whether or not we could tell based on the hospital characteristics if they're more likely to be included. So this is MedPAR over Encounter or MedPAR versus the entire universe of stays in both files. It looks like, urban hospitals have maybe more equipped to report their MedPAR stays to CMS. Once we get to critical access hospitals, less likely. So if you're going to rely on the MedPAR, you're going to get fewer critical access hospital stays. We thought, based on the reasoning for hospitals to submit to CMS where their stay would appear in the MedPAR, If they are receiving DISH and IME payments, they are the most likely to, and especially IME, likely to show up in the MedPAR. So that is true, although I was surprised that it wasn't 100%. But and then, you know, larger hospitals, probably those with more resources, have more stays that appear in the MedPAR. When we look at tercile of admissions covered by MA, definitely the more admissions, MA admissions a hospital has, the more likely they are to show up in the MedPAR. And again, that's probably related to recovering their payments. We wanted to do the flip and see, you know, which ones are only in the MedPAR, they're not found in the encounter data, to see if, you know, we could tell by the size of the organization. There's not a real strong relationship here. Some contracts are very, very large, of course, and those have more stays that, or, you know, fewer stays that are only in the MedPAR, which is good. You know, their encounter data may have more information, but there's a kind of a spread there. So we did find the encounter inpatient data match the MedPAR 85 to 90% of the time. It's kind of improved over time, and MedPAC has done more information on that, or more on that recently. You can use the NPPES in conjunction with the encounter data to help determine type of stay. You know, it's really handy for rehabilitation stays, for example. If you're trying to calculate readmissions, you'll know, did they just get admitted to rehab, or did they were they actually readmitted to the same place, or, you know, a different hospital, or transferred to a different hospital. Larger urban hospitals who receive Medicare policy payments and serve a large proportion of Medicare Advantage are the most likely to appear in the MedPAR. And MedPAR stays that do not appear in an encounter patient file do vary by plan.